Good morning and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network and the UNC Lineberger Comprehensive Cancer Center. It is October 15th, 2018, and this is our North Carolina Community College Lecture Series, System Lecture Series. Thank you so much for being here today. This series is specifically designed to introduce community college students in health-related fields to oncology and an opportunity to learn about many of the different aspects of oncology-related fields. A few preliminaries and then we'll get started. If you need to get a hold of us, best thing to do is call us 919-445-1000. If there are any technical issues, we hopefully can resolve those right away. So don't delay, do give us a call. You can also email us at unccn@unc.edu. We are available on the web at unccn.org. You can find out about future lectures, watch videos from past lectures. We'll talk a little bit more about that at the end as well. We're on Facebook, we're on Twitter, we're on Instagram, we're on YouTube, lots of places to find us. We will be using poll everywhere, and I want to encourage each and every one of you attending today to please go ahead and answer the polls. It's all anonymous, and it really is a nice way to interact with our presenter. It allows her to find out a little bit more about what you're learning and gets you engaged with the process. So if you have a computer with a web browser or a smartphone with a web browser, the easiest thing to do is just go to pollev.com, pollev.com/UNCCN. As the questions are appearing, you'll see them on your web browser. You may respond to those there. You can also go ahead and use any phone with texting capabilities, and the way you do that is you text to the number 22333, the letters UNCCN. You do that one time, you'll get a little message back saying joined, and then you can go ahead and respond to the questions via text. So again, you're sending to the number 22333, the letters UNCCN, just one time. You'll get a response back saying joined, and then you can go ahead and participate that way. And our first polling question is, colorectal cancer is the blank leading cause of cancer-related deaths in the United States. If you know this, great. If you're not sure, go ahead and take a guess. If you think it's the first leading cause, you'll put A, second, B, third, C, or fifth, D. So go ahead and once you've joined A, B, C, or D, go ahead and send that in, and we'll look at your results in just a minute. And without further ado, I want to welcome Tammy Triglianis. Thank you so much for being here today. Well, let's see. Tammy has worked as a certified nurse practitioner in the Gastrointestinal Oncology Division of the UNC Lineberger Comprehensive Cancer Center since 2008. She holds a dual certification as an adult nurse practitioner as well as an oncology certified practitioner. She also serves as an adjunct faculty member at the UNC School of Nursing, where she mentors nurse practitioner students. Her area of expertise is working with patients undergoing chemotherapy treatment for GI cancers. Her clinical interests include working with patients on clinical trials, survivorship, and quality of life while undergoing cancer treatment. So thank you for being here today. Maybe you can tell our listeners a little bit about your professional trajectory and what led you into nursing and particularly working with cancer patients.
Sure. Honestly, I grew up always wanting to be a nurse. I can't even remember the first time that I said that I wanted to be a nurse when I grew up. And when I went into nursing school, I had this vision of working with cancer patients. I wanted to have an impact in an area where people are in a pretty sensitive, stressful period, and working with the death and dying can be pretty challenging, and I had this vision that I wanted to help people during that process and hold people's hands during that process.
Well, we're glad that you chose that area, and thank you so much. Let's take a look at that poll, see how folks are doing. So again, go ahead and respond to this if you would. If you think that the first leading cause of cancer-related death is colorectal cancer, you'll put A. Second, B. third C or fifth D. And it looks like we're already trending. How are they doing?
Yeah, very good.
All right, so second leading cause of death. All right, and without further ado, caring for the patient with colorectal cancer, I'll turn the controls over to you. And feel free to use the mouse as a cursor if that's helpful.
Okay, great. Thank you.
Thank you.
So good morning. Thank you for joining me today in talking about caring for a patient with colorectal cancer. I appreciate this opportunity. Bear with me as I'm on the tail end of a cold, so excuse my voice for today. So first, to review our objectives, we'll discuss some signs and symptoms of a colorectal cancer, look at risk factors, stress the importance of screening and early detection. I'll go over how we stage a colorectal cancer and principles of treatment, not talking more specifically about treatment, but a broad overview. And then we'll wrap up with survivorship guidelines and talking about some healthy and lifestyle interventions. So our first poll question, nobody in my family has a history of colorectal cancer, so I am not at risk.
And so far, they are looks like they're saying that B, that's false. So we have 100% on B with false.
Yes, that's absolutely correct. And as we'll see in a few slides, that most colorectal cancers happen sporadically and are not related to any family history. So here is our agenda. I'll pause for you all to review. First, an overview of colorectal cancer. It refers to a malignant condition of the colon and the rectum. Oftentimes you'll hear them grouped together because they do have similar features, but are termed differently because they originate in different sites and ultimately are treated differently. So some statistics for colorectal cancer. It is the third most common cancer diagnosed in men and women in the United States. As we all know from our first poll question, it's the second leading cause of cancer-related deaths. The lifetime risk for men is 1 in 22, 1 in 24 for women. Most cases do occur in the colon at about 71%, and a smaller percentage occur in the rectum at about 29%. But the good news is survival rates are increasing for colon cancer due to increased awareness and screening. So when we look at new cases by age group, we could see most cases occur in that 55 to 84 age group. But on the tail end of that, the older than 84 and in that 45 to 54, 55 age range, we're seeing more and more cases in that age group. This is also important to note when we talk about screening coming up. So we'll move on to risk factors, which include some genetic and non-genetic risks. But I'd first like to note that having a risk factor does not mean that you will get a cancer. And not having any of these risk factors doesn't mean that you will not get a cancer either. So some non-modifiable risk factors, or those factors that you cannot control and change, are age. More than 90% of cases occur in age 50 years or older. Familial risk factors are a first-degree relative, a parent, a sibling, a child who has been diagnosed with a colorectal cancer have about a 2 to 4 times the risk of developing the disease compared to people without this family history. The risk is even higher with more than one first-degree relative diagnosed. And then there's a small percentage that are inherited related. These are related to most commonly Lynch syndrome, and second most common is familial adenomatous polyposis, or FAP. Other non-modifiable risk factors include a personal history of high-risk adenomas or polyps, and inflammatory bowel disease, for example, an ulcerative colitis or Crohn's disease. So we look at those non-modifiable risk factors based on incidence. Most cancers happen sporadically, about 70% of cases. Many people can have a family history, about 20%, but less commonly are inherited cancers at about 10%. So moving on to modifiable risk factors, or those factors that you do have control over and can change. So lack of physical activity, obesity, a higher consumption of red or processed meats, smoking cigarettes, alcohol consumption, and diets that are high in fat or low in fiber. So our next poll question is, 1 in 3 cancer deaths from colon cancer could be prevented with early detection.
All right, and if you think that that is a true statement, please go ahead and select A if you're texting, or B if you're on the web, or if you think that's false. So A if you think that's true, B false for texting, or you can just select that right online there if you're going through the browser. And I think I forgot to mention to our guests that we will have a Q&A period at the end, so you'll be able to text in your questions to Tammy at the end. So if you want to be jotting those down, thinking about those questions, you'll have that opportunity to share those. How are we doing?
Great. So yes, this is true. And the reason for it is screening. So now you'll hear my stressing the importance of colorectal cancer screening, because we can prevent deaths with screening and early detection. So some things to note about screening and why it is important. Many times a colorectal cancer does not cause symptoms until it is advanced. Early detection and diagnosis greatly affect survival. And unfortunately, only half of the U.S. population participates in colorectal cancer screening. And with regular screening, we are able to diagnose this cancer earlier when it is curable, and treatment can be most effective. Therefore, it is recommended to have regular visits with your primary care provider. Even if you are healthy and quote-unquote don't need a doctor, I do encourage everyone to have a primary care physician, to establish that relationship with them, to pick up on any subtle symptoms. Even some screening blood work can pick up on some subtle changes and prompt further testing on an earlier basis. And then adults, beginning at the age of 45. I have this age highlighted as this is a recent change with the American Cancer Society. They've lowered this age from 50 to 45 after analysis did show that there are increased diagnoses in this younger population. So they started recommending that we start screening at age 45. The U.S. Preventative Services Task Force still has an age recommendation of 50. So those screening tests could be a fecal occult blood test or a fecal immunochemical test on a yearly basis, a flexible sigmoidoscopy or colonoscopy about every 5 to 10 years, and stool DNA tests as recommended by your provider. Screening may begin earlier based on a personal or family history. For example, if a person was diagnosed with a colorectal cancer at age 50, their children should start screening at age 40. So essentially 10 years earlier than the person diagnosed with that cancer. So looking at those screening tests more closely, the stool-based tests include the fecal occult blood test, which can detect hidden blood in the stool. There are foods and drugs that may affect these test results, so they need to be avoided prior to doing this test. It is recommended on a yearly basis, and if positive, a colonoscopy would be warranted. The FIT test, or immunochemical fecal occult blood test, also tests for hidden blood in the stool, but with this test, there are no drug or dietary restrictions. Again, recommended on a yearly basis, and if positive, a colonoscopy would be ordered. The next test is a Cologuard, which is a stool DNA test for cancer or precancer detection. Colorectal cancer or polyp cells often have DNA mutations or changes in certain genes that this test could pick up. It is FDA approved and covered by Medicare. It's the only test available that tests for both the DNA changes as well as hidden blood in the stool. Recommended every 3 years, and once again, if positive, further workup would be indicated with a colonoscopy. So I cannot stress the importance of regular screening for colorectal cancer. Finding and removing polyps can prevent colon cancer or detect a cancer at an earlier stage. So next we'll look at signs and symptoms of colorectal cancer. And we'll first start with a poll question. Colon cancer often starts with no symptoms.
Right. So if you think that that is a true statement, go ahead and give us an A. A false statement, B.
You guys are doing great. Yes, true. And this might sound like a simple question, but I stress this enough because of the importance of screening. By the time a colon cancer does have symptoms, it is a more advanced stage. So in most cases, people with these symptoms don't have a cancer. We could probably all say we've had one of these symptoms at some point in our life. But if you do, and this symptom lasts for a longer period of time, it should be evaluated by your provider. So first is a change in bowel habits, diarrhea or constipation, narrowing of the stool, smaller calibrose stools, a feeling of urgency, or that you have to have a bowel movement and you do so, and that pressure and sensation is not relieved. And these symptoms are lasting for more than a day or two. Abdominal cramping or belly pain that doesn't go away. Rectal bleeding, any dark stools or black stools, or sometimes people can see bright red blood in their stool. Weakness and fatigue that's ongoing. And then unintended weight loss. So you're eating regularly but still losing weight. So how do we diagnose a colorectal cancer? So we talked about colonoscopy for screening, but it can also be indicated to evaluate a concerning symptom. And then, of course, a biopsy of any suspicious lesions that would be seen on colonoscopy. Some blood work, a complete blood count that can check for anemia, and then a comprehensive metabolic panel, which can identify any organ dysfunction, kidney, liver, and then a CEA, which is a blood work, a tumor marker, that is more specific to a colorectal cancer and can be increased when a colorectal cancer is present. It is not 100% specific or sensitive test. It is not used for screening, but is used for more monitoring during cancer treatment or surveillance. For example, this blood work can be slightly elevated in smokers, so non-cancer things can cause this blood work to be slightly elevated. And then a CAT scan would be ordered. This would evaluate any extent of disease and whether it's spread to any other organs. So how do we stage a colorectal cancer? So we use the TNM system, which is based on the size or extent of the primary tumor, or the T. And the next is the N, which is any spread to nearby lymph nodes. And the M is for metastases, if this cancer has spread to other parts of the body from the primary site. A number can be added to these letters to indicate the size or extent of the primary tumor or degree of cancer spread. So for example, we'll look at staging and how that translates into colorectal cancer staging. So a stage 1 cancer is a smaller tumor size, no lymph node or spread to outside organs. A stage 2 would be a larger tumor size, but again, no spread to lymph nodes or to a distant body organ. Then a stage 3 cancer can essentially be any size tumor, but now this has spread into the nearby lymph nodes, and again, no to distant organs. And then a stage 4 cancer, again, any size tumor, spread to lymph nodes, and now this has spread to other organs. So after a patient has a surgery for their colorectal cancer, then it's looked at more specifically for any molecular or mutations. It's important to understand that there are various mutations in certain genes, as these can serve for prognostic or predictive markers for treatment. So a colorectal cancer will look at microsatellite stability. About 85% of colorectal cancers are microsatellite stable. A smaller percentage, about 15%, are microsatellite unstable, or MSI high. This is important to identify, as most of these cases are sporadic, about 12 to 15%, but there is a small percentage of MSI high colorectal cancer that are related to Lynch syndrome or inherited. Further markers that we test for in a metastatic colon cancer or a stage 4 cancer is KRAS, which is a gene that can be found in colorectal cancers. It essentially acts as an on-off switch for cancer growth. Identifying this marker is important in treatment, as those patients with a KRAS mutation, or 40% of the cases, would not respond to certain targeted therapy medications. KRAS wild type essentially means that you do not have this mutation. BRAF is another marker we look at. Only about 12% of colorectal cancers have a BRAF mutation. This is an indicator for overall survival and unfortunately tends to have a poorer prognosis. And again, wild type means you do not have this mutation. So then, how do we treat a colorectal cancer? So there are different types of treatments. Depending on the stage and location, the oncologist may recommend one or more of these options. First is a surgery to try to remove the cancer. Another treatment is radiation, which uses high energy X-rays or other types of radiation to kill cancer cells. Chemotherapy is medications either by mouth or IV that help kill cancer cells to try to stop cancer growth. And then targeted therapies are medications that identify and attack specific cancer cells. And this category is the importance of identifying those KRAS or BRAF mutations. So how we treat a colorectal cancer by stage. A stage 1 cancer would be surgery alone. This has a 5-year survival rate of about 92%, meaning 92% of people will be alive at 5 years. A stage 2 cancer, again, surgery, the 5-year survival rate is anywhere from 63 to 87%. And a stage 3 cancer is surgery followed by chemotherapy to try to decrease cancer recurrence. And this has a 5-year survival rate of 53 to 89%. And a stage 4 cancer uses chemotherapy and a targeted agent, and sometimes surgery can be indicated for certain cases. And this has an 11% 5-year survival rate. Again, stressing the importance of identifying this cancer at an earlier stage. So we'll look at some case scenarios. Our first case is a 61-year-old male. He's had a screening colonoscopy every 5 years. He's had regular follow-ups with his primary care provider. In his most recent screening colonoscopy, he was found to have a colon mass. His diagnostic workup included a biopsy, which did confirm an adenocarcinoma, and a CAT scan showed that there were no evidence of spread of this cancer to other organs. His treatment was surgery, which removed his cancer, and he was diagnosed with a T3, N0, M0, or a stage 2 colon cancer, and no chemotherapy was recommended. Only about 4 to 5% of patients with a stage 2 colon cancer would benefit from chemotherapy. Our second case is a 64-year-old female. She was a smoker. She did not have regular follow-ups with a primary care provider. She did have a colonoscopy about 15 years ago in which she had polyps removed. So again, a risk factor for this cancer. She ended up going to the emergency room with abdominal pain, nausea, vomiting, as well as constipation for about a week and a half. Her diagnostic workup included a CAT scan, which did show a large bowel obstruction without spread of disease to distant organs. She had a flexible sigmoidoscopy and a biopsy of a malignant mass in her sigmoid colonoscopy, which did confirm an adenocarcinoma. After she had surgery to remove her cancer, her pathology was a T3, N2, which spread to nearby lymph nodes with no spread to distant organs. So she had a stage 3 colon cancer in which she received adjuvant chemotherapy, meaning a treatment after the cancer was removed to lower her risk of cancer recurrence or this cancer coming back. So here we could see the benefit of adjuvant chemotherapy in a stage 3 colon cancer. First, looking at management without chemotherapy, we can see that 60% of cases will be cured with surgery alone, and 40% of cases will recur. For those treated with chemotherapy, again, 60% will be cured with surgery alone, and 22% their cancer will come back, And 12% will be their disease-free survival, meaning that this cancer does not come back. It's about 12% with one chemotherapy drug. And when we add a second chemotherapy medication, that adds an additional 6% improvement in overall survival, in disease-free survival, excuse me. So our last case is a 57-year-old male who never had a colonoscopy. He did not have regular follow-up visits with a primary care provider. He had a grandmother who had a colorectal cancer, and he reported a history of intermittent black stools, rectal bleeding over a 6-month period. He did go to the emergency room with complaint of weakness and shortness of breath. On his diagnostic workup, he had blood work, which he was found to be severely anemic. His CAT scan did show a colon mass with multiple lesions in his liver, and a biopsy did confirm an adenocarcinoma. His treatment recommendation was systemic chemotherapy plus a targeted medication. So I wanted to show this CAT scan of this particular patient. So in that first picture, the before picture, you're looking at a picture of his liver where the red arrow is pointing to. So his liver is quite enlarged, and that darker area is cancer. So you can see a pretty significant amount of cancer in his liver. About 2 to 3 months after starting chemotherapy, we repeat a CAT scan to see how this treatment's working. And he had very chemo-responsive disease. In that second picture, or the after picture, the red arrow was pointing to his liver, which you could see it has shrunk down and has a lot less cancer. That dark area is the area of cancer after chemotherapy was started. So chemotherapy can be very effective in prolonging people's life. It will not cure this cancer, but definitely extended his life and improved his quality of life as he had less cancer burden. So other treatment options for a more advanced colorectal cancer. One is immunotherapy. I'm sure you've all seen this in the news. There's billboards. Immunotherapy is used in colorectal cancer in very specific cases. It is shown to be effective in microsatellite high tumors, those MSI high tumors, which is, a small percentage of colorectal cancers. And then there's clinical trials. Research studies are used. They're meant to try to help improve current treatments or obtain further information about current treatments. They look at new medications for cancer, as well as different combinations for cancer treatment. So we'll wrap up spending some time talking about survivorship. So survivorship can be pretty challenging as this looks different for everyone. It's essentially life after a cancer diagnosis. It begins at diagnosis and includes people who are on a long-term cancer treatment or even those that have gone through a surgery or any type of treatment and have completed therapy. It includes surveillance and prevention of recurrence or trying to identify a recurrence earlier. It is surveillance of any medical or psychological effects of cancer or cancer treatment. Interventions for late or long-term side effects of cancer and cancer treatment, and certainly promotes health and quality of life. So symptoms of some long-term side effects of having a cancer or cancer treatment. Anxiety is pretty significant, especially fear of recurrence. People are very much more in tune to their body and any changes after going through a cancer diagnosis. change in bowel function from surgery, from radiation, can have nerve damage from these treatments. This is also can affect sexual dysfunction, as well as urinary incontinence, both related to surgery, nerve involvement. Peripheral neuropathy can be a pretty significant side effect from one of our chemotherapy medicines we use. We pay close attention to this specifically while people are going through chemotherapy. Fatigue is probably the one that lasts the longest, or people have the most trouble overcoming. I think stamina and endurance probably take the longest to get back to their baseline or before their cancer diagnosis. So follow-up care, patients who have gone through a cancer treatment, have had their cancer removed, essentially do not have cancer in their body anymore. We follow them for a total of 5 years. We do a history and physical exam every 3 to 6 months. We check blood work, the CEA, every 3 to 6 months. We evaluate a yearly CAT scan and a colonoscopy at 1 year, essentially a year from their cancer diagnosis or surgery, and then repeat one about every 1 to 3 years. And this is based on whether polyps were removed, which would be an indication for people to have more frequent colonoscopy screening. And then greater than 5 years after a treatment, people can return to their primary care doctor for regular follow-ups and health care maintenance. So I certainly spend a lot of time talking with my patients about healthy lifestyle. I think things that people are able to have control over and influence, definitely they feel more empowered. I talk with people about maintaining a healthy weight, engaging in regular physical activity, and I really mean just walking 3 to 5 times a week, getting your heart rate up. I tell people strolling through the mall does not count. It has to be to get your heart rate up and get your blood flowing. Maintaining a healthy diet, getting all your vitamins and nutrition through healthy fruits and vegetables and whole grains is important. Avoiding tobacco products, avoiding or limiting alcohol consumption. A low-dose daily aspirin can be indicated for some people. I warn people if there's a contraindication, for example, stomach ulcers where people have a higher risk of bleeding, to not take a daily aspirin, but there is evidence that this can decrease polyp formation, which can ultimately turn into a colorectal cancer. And then tree nut consumption. So in stage 3 colon cancer, it has been shown that those who consumed about 2 ounces of tree nuts, walnuts, pecans, almonds, per week had a 42% lower chance of cancer recurrence and about a 57% lower chance of death than those who did not eat tree nuts. And I think we all know that peanuts don't count. They're technically a legume. So I know this slide is very busy. I don't expect you all to take all this in, but the point of this slide is that there are lots of resources out there for colorectal cancer patients and their families. There's a lot of reputable and not reputable resources, and I talk with people about referring to more reputable websites and getting real information, because there's a lot of stuff out there that causes a lot more stress and anxiety for people than is necessary. And then my next slide is more UNC-specific resources that I refer people to, our Lunch and Learn, our telehealth lectures. At UNC, we have a transitions program for those patients that have undergone a cancer treatment, and how do they get back to life after cancer? And it's a 4-week program to help people navigate that. And there's also some mindfulness programs which may be appropriate for some people and helpful. So my takeaway for you all today is know your risks, get screened when appropriate, and consult a professional, have regular follow-ups with your primary care provider, live a healthy lifestyle, and most importantly, get out there, spread the word to your friends and family. And thank you for joining me today.
All right. Thank you, Tammy. This has been great. We hope that you will take a few moments now to share some questions with us. And also, and I'm going to skip ahead for just a minute here, and I want to say please don't finish this activity without taking a moment to share an evaluation with us. This is really important for our program. You can just go to unccn.org/eval, or you could go evaluation. That would get you there. But either way, but just eval, unccn.org/e/eval. Go ahead and take just a couple of moments. You can see it's a very short form there. We really count on all of our participants filling out those evaluations, and that helps us to continue to grow and improve our program. All right, so I'm going to go back to, it'd help if I went the right direction. There we go. I'm going to go back to where we've got our place where you can submit questions. So if you've already been using Poll Everywhere, you can just go ahead and use that same format, whether you're texting or whether you're on the web, and go ahead and please share your questions for Tammy with us. I wrote down a few as well. Let's see. Yeah, one that I was wondering about is what's changing. You mentioned, and what do you expect to see in terms of the future with colorectal cancer? I know you mentioned that the suggested screening had gone down for one group from age 50 to age 45, and now we're seeing in the news some stories about higher incidence in even younger populations with colorectal cancer. Do we think that might jump down to 40 at some point? Do we think that we'll start to get a handle on why we're seeing some of this increased incidence of colorectal cancer in a younger population?
Yeah, that's incredibly difficult to answer, but yeah, it's certainly concerning that we're seeing younger patients. Are we just, increasing our screening and identifying these things earlier? Are people's diets playing a role? I don't know that we...
And clearly, no one can know for certain, but it does seem that we're seeing more of that, and so maybe even younger screenings at some point.
Yeah, absolutely.
What are your thoughts on potential areas for research with regards to the organizational factors in colorectal cancer screening, treatment, decision-making, survivorship? It's a big question.
Yeah, I'm not sure.
So maybe focusing on that areas of research where we might see more research moving forward.
So certainly cancer screening, if we're at a point that only 50% of the population are undergoing colorectal cancer screening. What's impacting why people are not getting screened? Certainly an area of research to get people participating in screening earlier, as this is huge and a cost saving to minimize the amount of cancer treatment and less deaths from colon cancer.
At age 45, can you substitute a colonoscopy with a fecal blood test, or is that test only for certain ages or situations?
Well, so it's not necessarily substitute. Recommendation is for fecal occult blood test or colonoscopy. Unfortunately, insurance companies are actually impacting this. So I was reaching out to my insurance company for my husband, who is not quite 50 yet, but they won't pay for colorectal cancer screening because the U.S. Preventative Task Force is still recommending age 50. So insurance companies are still affecting this screening guideline. I did write back to them and copy and pasted the American Cancer Society guidelines, so I'm waiting for a response back from them. But yeah, certainly a colonoscopy, can be done. There's not a high compliance with the fecal occult blood test. I think it's an awkward test for people to do at home. Food playing a role. So there's not a lot of adherence for that. But hopefully, getting the word out, people can, get more involved with taking ownership of their own screening.
Great, great. And this looks like, I'm not sure if this is from the same individual, a similar question. At age 45, can you substitute the colonoscopy with a fecal blood test? You can talk about those tests only before age 45.
No, I mean, the age 45 by the American Cancer Society recommendation was for average risk fecal occult blood tests or colonoscopy or visual exam. So it's a or. It's not necessarily a step-by-step process. I think probably most primary care provider offices may be doing the fecal occult blood tests, cost, but doing it on a step-by-step basis. But it's essentially an or in the recommendations.
All right. And what maybe in finishing up, what are some of the for our students? What are some of the different fields that they may have the opportunity to study that would be involved with treating the patient with colorectal cancer?
Oh, that's primary medicine, getting people to go through their healthcare maintenance for screening, not only for colorectal cancer, but other cancers as well. Once diagnosed, nursing, there's various research opportunities, the pharmaceutical companies getting involved with, these treatments, a physician, the surgery side of cancer treatment, certainly the psychological aspect of a cancer diagnosis, psychiatry. I definitely work with my cancer support program colleagues in helping, care for my patients, as it's not just a, physical diagnosis. There's an emotional component to this, and addressing all of those factors, I definitely play a role in how patients cope and do, and I've seen it make a difference when you can help promote the whole mind, body, spirit.
Great, great. And I was glad to see you talk about survivorship. We had Deb Mayer on a few months ago talking about creating a survivorship plan, and for anyone who would like to find out more about that, you can go to our video recordings, and Dr. Mayer is there with a hour-long presentation on the survivorship plan.
Yeah, Deb is great. I've worked closely with her, and certainly her work in survivorship has definitely influenced how I take care of my patients and the focus of survivorship with my patients.
Great. Well, let's take a look at just a few other things. You knew I was going to come back to that survey, so please take just a few moments to fill out that survey, unccn.org/eval. And you can just go ahead and fill that out and submit that. We really appreciate that, I'm going to say in advance. We want to thank the North Carolina General Assembly for their generous support of the UNC Lineberger Comprehensive Cancer Center through UCRF, that's the University Cancer Research Fund. We also want to thank Thomas Shea, Mary King, Veneranda Obore, John Powell, Gene Sellers, all for their work that they do associated with this presentation. We do have more community college lectures coming up. We have on November 19th, Caring for the Patient with Melanoma and Other Skin Cancers. with Dr. Colicchio and Dr. Thomas, and then February 11th, Caring for the Patient with Head and Neck Cancer, and that's with Hazel Hampton and Stephanie Shea, so we hope that you'll join us for both of those. We have another one coming up in March. You can find our complete schedule by going to unccn.org. We have self-paced courses, and this is exciting. This course and other courses can be taken as self-paced courses. So if you're watching this as an instructor, you can assign these to your students. If you're watching these as a student, you can go ahead and watch one of these online and take a short evaluation and then print out a certificate, which is proof of mastery of the activity. All of that is at learn.unccn.org. The newest ones, we have Caring for the Patient with Leukemia, Lymphoma, or Multiple Myeloma, and End-of-Life Care Options for Patients with Cancer. So all of that, learn.unccn.org. That's all free. Just log in. You go to the site, you create a username and password, and then you can go and take as many of those courses as you want and receive those certificates. And again, that's all free. Thank you so much for participating. We look forward to seeing you at future lectures. Please spread the word. Please check us out on the web. Find all those lectures, like the one on survivorship, like this one, and many others. They'll all be there. All right, Tammy, thank you again. We really appreciate it.
Thanks for having me.
All right. Thank you all. Until next time.